6 to 8 free counselling sessions for all of our members, because again, that's something that's really hard to access via the NHS. So that's kind of what we do in a whistle-stop tour, but we basically just offer as much support in all areas of the POI diagnosis from start to finish as much as we can.
Perfect. Thank you very much. And also we do have Hazel Hayden, who is the director and founder of Bristol Menopause and Wellbeing Clinic, and also a British Menopause Society specialist. So thank you for joining us, Hazel. I don't know if you want to just talk a little bit about yourself, introduce yourself.
Yeah, hi everybody, I'm Hazel. Some of you might well know me. I started at Bristol Menopause and Wellbeing Clinic in 2019. I'm a British Menopause Society specialist, as Tia said. I'm also a trainer for other doctors and nurses who want to become advanced specialists in menopause. So I do that as well. So that's part of it. I've been working in women's health and particularly menopause since 2006, and I have seen it hugely, and it's sort of gone full circle in many ways in that time. And I know awareness of POI is improving, and if any of you were thinking about, oh, why does that say 2024 update, what I'm going to talk about is the ESURE guidelines that were updated last year. So that's why it says 2024 and not 2025. And I'm just going to start off with a quick presentation, only because it just sets the scene. And then once I've done that, we can have a chat. If you want to ask Amy or I, or even Tia, any questions in the middle of it, please just put your hand up in the box, and we can stop and have a chat along the way. There will be time at the end if you want to have a chat then, but that's it. Yeah, Tia, over to you.
Perfect, thank you. Just obviously I did mention it when the webinar link went out, but we will be recording this webinar. So if you want to stay anonymous, please keep your, I can see everyone's got their cameras off anyway, but please keep your cameras off, and please keep your microphones off to avoid any background noise. Obviously, if there is any times we need you to put it on, then please obviously feel free to. Anything for any questions, even if Hazel or Amy are talking about something, you have a question about a specific topic, just pop it in the chat box and we'll answer it, or we'll do a Q&A at the end. Yeah. So I'll hand over to you, Hazel.
Thank you. Thanks, Tia. First of all, I just want to say that although we call it premature ovarian insufficiency, it is menopause by any other word. So anybody who says, if you see anyone who says they're trained in menopause, then actually, if they're trained in menopause, they should also be POI specialists as well, because it is part of the British Menopause Society Advanced Certificate. And it's really important to say that, and you can't pass and get that certificate if you haven't got some specialist training in it. Why we're here tonight is to understand what premature ovarian insufficiency really means, and it's really difficult for a lot of women to get it diagnosed. And I'm going to share what's new in care and support and the 2024 global guideline, and to offer answer, support and a bit of clarity if we can, and to remind you that you're not alone. And I've got quotes here because I've seen a lot of women with POI, and I can remember my very first woman that I saw with POI, who was a 26-year-old girl who had suddenly gone into it, and she'd been misdiagnosed for years. And this is her quote. It felt like I was grieving a part of myself and no one had the words for it. So tonight is a bit about finding those words and better support if we can. So what is POI? So it means that your ovaries stop working normally before the age of 40. And this ESURE guideline, that's been done with a whole group of different people, Monash University over in Australia, there's lots of things, the Europeans as well. It can mean irregular or missing periods, and usually with a high FSH, which is our follicular stimulating hormone, which gets our ovaries to produce an egg and to produce estrogen. And once that starts rising, it rises because it's trying to hit the ovary to tell them to produce an egg, and it starts rising because the ovaries aren't producing that egg, and that's a sign that our estrogen and our ovarian reserve is disappearing. It's much more common than we think. And when I first did my first training in menopause and POI back in 2006, we thought it was 1% of women. But actually, we now think it's 1 in 25, which is 4% of women. And because we're only learning about these things more now, I wouldn't be at all surprised if that number went up. Not by lots, but by an amount. So, definition: it's the loss of ovarian activity before the age of 40. And it's usually if you've had 4 months of amenorrhea or oligomenorrhea and an FSH of 25 or above on one occasion. It used to be that we had to do an FSH on 2 occasions, 6 to 8 weeks apart. And that's now been changed. And this was these new guidelines. And, you know, we are shocked, and it is still under discussed, and it's not thought about, and getting a diagnosis can take a long time. So what causes it? We don't always know the reason. I always say, this is actually from eSure, what they've said. You think of it like a puzzle with many possible pieces. So genetics, so Turner syndrome is a classic. Family history, if you've been through cancer treatments or chemotherapy, or even if a woman's had if you've had surgery to remove ovaries, then that's going to, and you're under the age of 40, that's going to put you into POI as well. And autoimmune conditions such as thyroid disease. And as well as, and this hasn't always been discussed, if you've got a low weight, if you're a smoker, or if you have a lot of stress in your life. And so if somebody stops having periods through a period of high stress, and those periods don't return for quite some time, the chances are that they will probably go into POI. And environmental toxins. But more often than not, we don't really know the cause. It's just what's called idiosyncratic, I'd call it, just one of those things. And this was another quote from somebody else. I didn't do anything to cause this, but I blame myself anyway. This woman was another younger woman, and she thought it was because she hadn't eaten. She'd had a really low weight when she was 16, and she thought this is why it had happened to her in particular. So how is it diagnosed? So missing periods for 4 months or more, a blood test showing FSH levels higher than usual, and other tests to check for possible cause or health risks. So actually, when we don't just look at your FSH alone. We need to be looking at vitamin levels, thyroids as well, and that's really important. The new guideline says just one blood test, and that if it's clearly high, it's usually enough to confirm POI. So no, should not be any long waits for repeat tests if it's clear. However, it can be more complicated than that, because obviously with POI, there might be one time you get the blood test done and you've ovulated that month, and that can happen. So how might someone be feeling? Sadness, shock, grief, anger is a big one that I've come across a lot. Anger, why has it happened to me? Because of the consequences of it. And also frustration. We have a lot of women at the clinic who are aged somewhere between 30, I'd say 32 and 39, who actually have POI but haven't been recognised that they've got it by their GPs. And that's a really difficult one because it can take years to get a diagnosis. So hot flushes, but that might not happen. Poor sleep, joint pain, brain fog, low mood, low energy, classical menopausal symptoms. But actually, a lot of women get told you're too young for this. And actually, that's not true. And then the fear about fertility, as well as feeling old before your time. I had somebody in last week who I started treating when she was 38, and she is 42 now. And she said she's a real fitness. She runs retreats. She goes over to Portugal. She works with someone really famous who does retreats over there. And she said, I felt like an old lady and nobody would listen to me. But you lose your confidence as well as your periods. So, key messages to hear. You can still get pregnant. Up to 10% of women with POI do. Contraception is still a conversation to have, especially if pregnancy isn't your plan. And I've got a lady who I saw on Tuesday who has POI, got raised FSH. She is 32. She doesn't know if she wants to get pregnant or not. So we had that discussion about she needs to think about the pros and cons, because she needs to start trying sooner rather than later. There is support. So the Daisy Network are excellent. And there's apps and groups and counselling. And I don't know if Emily's coming on here this evening, but there's Emily as well, who runs a local thing. Tia, is Emily on here tonight?
Not that I'm aware of.
No.
But yeah, she runs a group for people. So if you've obviously conceived, even if you're at the stage where you have, so if you've conceived naturally or through IVF, donor conception, or adopted, she runs a support group called Mothering in the Menopause. So when you're at that stage of your diagnosis and you've if that's obviously your plan to have children, whatever that path may look like, then she does have a support group to support you, obviously mothering whilst going through the menopause. But yeah, I'm not sure if Emily is in here tonight. Just a quick question, Hazel, someone's put in the chat. Is the POI diagnostic threshold for FSH level still under 25?
Yeah, it is. But do you know what? I don't know what Amy thinks of this, but actually, if somebody's not had a period for 4 months, or I would be, and their FSH, often their FSHs might be a little bit below that, then I'd still think, especially if you're younger, that you need treatment. And that's the thing, because it's really important, because actually you have lost your hormones, and they are so important for your bones, your health, and your brain, which is what I was going to talk about. So people say, oh, we shouldn't treat with hormone replacement therapy under the age of 40. Actually, it's so important to treat under the age of 40. So although that is a cutoff, they do consider it a cutoff, but if you've got symptoms and you're missing your periods, you still need to be treated. Does that answer the question?
Hopefully so. They've not said it's not. So hopefully, I'm sure obviously they'll pop back in if it's.
Amy, have you got anything to add to that?
I think as you're saying, I think what we find a lot is that actually with POI, a lot of the diagnostics you have to look outside of the rule book a little bit, because it is such an individual, tailored thing for each person, each circumstance. Of well, there are these diagnostic sort of levels to meet. Quite often they don't fit everybody, and I think
I'm so glad you said that.
It takes a good clinician really to have the confidence to look outside of those, strict guidelines, essentially, because there is a lot of maneuvering that's needed with POI.
And it can be, I mean, I know with the women we see, it can be a real fight to get the keys to treat them, but you have to think outside the box. And actually, my argument always is actually, if we treat you for 3 months with hormones and you feel better and your symptoms go and you feel a whole lot better, then actually that was the right thing. And giving you those 3 months of hormones is not going to harm you particularly in any way. That would be my argument all the time, and that's what I would always say about it. And it is about, yeah, so having that advanced certificate and that specialism as a menopause specialist gives you that right to be able to say, this is my argument, this is why I'm going to do it. And it's surprising how many women then say, I feel like myself again, because that's a big issue, and they wish somebody had said something to them sooner. I hope that answers that question. So if you have POI, hormone therapy, and rather than call it hormone replacement therapy, it is actually hormone therapy. Although it's the same as what you get if you were older, we call it hormone therapy, and you should be taking it until your early 50s, even if you feel okay, because losing your estrogen below and your progesterone below the age of 40 has huge consequences for your heart health going forward through life. So bones, because once we start losing estrogen, the risk of osteoporosis, especially if you lose it under the age of 40, is much bigger. And it's surprising these younger women who have osteopenia very young if they haven't been treated adequately even. And that's the other thing to say, is about having it being adequately treated. Every bit of treatment should be individualized to each person, but it's not a one size fits all. So often if you're younger, your need for hormones is going to be higher than someone who's 51, 52. And so that 50 microgram patch or that 2 pumps of gel might not help at all. And for somebody with POI, it's not necessarily going to protect your bones. Also, our heart as well, so it protects us from cardiovascular disease. Estrogen in our bodies helps our blood vessels stay nice and flexible. So our risks of high blood pressure increase as we lose our hormones, and especially when you're younger. So that increases your risk of cardiovascular disease as you get older. And as I know, heart disease is the biggest killer of women at 60. So 60% of women's deaths at 60 will be cardiovascular disease, whether it's heart attack or a stroke. Also supports our brain health and our mood hugely, and that's really important, as well as sexual well-being. Not only if you've gone into POI do you not feel great necessarily, but actually libido disappears because ovaries have shut down, so you're not producing progesterone or estrogen, and your body is looking for those, particularly estrogen, wherever it can, so it will grab hold of that testosterone. You're probably, because you're younger, your testosterone goes. So it's really important with women with POI. They don't just need the estrogen and the progesterone replaced, because we give you progesterone to ensure the lining of your womb, if you've still got a womb, a uterus, is thinned out, because giving you estrogen alone will thicken that up. So by giving you progesterone, that thins it out. But actually, for a lot of women, progesterones are calming and relaxing hormone. So one, it helps you sleep, and two, it also can help reduce anxiety. But testosterone should definitely be added to that as well on the whole. And yeah, so that's what it's about. And it is trying to make, it's giving you what your body will be making naturally. It's not an add-on, and it's not an option. You know, it's not, oh, I won't bother with it. Actually, it's a need to have. So fertility and family planning, and this can be a difficult conversation, and especially in these times where fertility clinics are not always cannot always help. You don't, but the younger you are, and it's really important that if you want, it's really important to speak early to a fertility specialist, and that's really important. And then there's options of IVF with donor eggs, fertility preservation before cancer treatment, if that's an option, and then exploring other family building paths and donor conception, and other things like that. There's lots of other programs that can be done as well. So taking care of your health is really important, as I talked about already. So bone health, getting a DEXA scan. As a young woman, you should have a DEXA scan done, which is a bone scan to see what's happening, because once we start losing this estrogen, our bone mass and our density drops by 50% of where it should be. It drops by 20%, 50% of what men's is. And it's really important to keep active. Weight-bearing exercises are really, really important, as is strength training as well, building muscle, because losing estrogen will mean that your muscle mass will not be, you'll lose muscle mass as well. And taking enough calcium and vitamin D. That's just, so calcium, 1200 milligrams, and vitamin D, a minimum of 400 micrograms. So I would say probably 800 is really important. And it's also important to keep an eye on your blood pressure, your cholesterol. You should be having, if you do get diagnosed with POI, you should at least be having a yearly checkup with your GP to just check all these things: cholesterol, weight, blood sugar yearly, because when we lose our estrogen out of our liver and our pancreas, we're at higher risk of insulin resistance. And I've noticed in our clinic, we do blood tests on women, and I'm not talking about younger women necessarily, but I've noticed that women who haven't had HRT, their insulin resistance is significantly higher, which is interesting. And then POI can really affect mood, memory, and libido, which I've already talked about. And it's that whole loss of part of you, and feeling a woman, and that's really important. And that's where the things that people like the Daisy Network are really important with their counselling support. And then what helps: hormone therapy, regular checkups, bone scans and blood tests, support groups and apps, talking therapy, and it might well be that you do need some psychosexual therapy and CBT. And then thinking about, so I've written exercise, sleep and connection, and I was thinking about it today. The other thing that's really important is, exercise, sleep, getting 7 to 9 hours a night is really important, but actually stress levels and anxiety are hugely important, because if you're stressed and you have anxiety, that's all going to make all your symptoms a whole lot worse. And it's easy for me to sit here and say, oh, don't worry about your stress and anxiety, but I can't wave a magic wand to get rid of all that. But actually, it's just simple things: 10 minutes a day for yourself. Journaling's another really good thing. But when you have something, this happens, the big thing that I've noticed a lot is you lose connections as well. You don't want to be sociable. Somebody else said to me the other day, I don't want to see my friends anymore because they don't want to talk about it because they're not going through it. And that's really hard. So it's trying to keep that connection with other people, friends, wherever you can, and having a really good support network, family, friends, whoever, even work colleagues. And things like this should be taught more and more in the workplace. So what's new in the new guideline? So it's the European Society of Human Reproduction and Embryology, ESHRE, and just one test needed for diagnosis. And that's, I think they've done that for our the NHS and those things. New advice for teenagers and cancer survivors, expanded list of genetic tests, and they've got better guidance on muscle strength, mental health, and non-hormonal options. And I think that's it. So that was just setting the scene. And now I was just going to talk Anybody got any questions? Amy, have you got anything you want to add to that? Because you've got loads to add to that.
Yeah, I think sort of a few things on the kind of the psychological aspects of POI. I think you touched on a few of them there, and I think that's something that is quite often missed, I guess. There's a lot of grief and loss that goes with this diagnosis. I know you mentioned how there's a lot of people that feel like they're missing a part of themselves and who they are. And I think that's something we hear a lot, is this sort of notion of where do I fit in the trajectory of womanhood, I guess, because
Absolutely.
you go through puberty and then your periods, and then there's the fertile years where maybe your friends are getting pregnant, and then maybe your mum and nan are going through menopause, and you kind of don't fit in any of those spaces. You don't fit with your mum going through menopause, but also your friends are talking about periods and fertility, and you don't fit there either. So it is this really individual space where I think only people with POI can understand, because it completely changes this sort of womanhood plan that we all expect to go on. And I think there's, again, on that, there's the loss of this of your life plan, and I think it's important to know whether you expected to have children or not, whether children's something you wanted in your plan. Having the choice taken away is still a huge thing. So actually, a lot of women that have already had children and then go through POI feel a bit of guilt about being devastated about the diagnosis. But what we always say is, actually, even if you've already got children, doesn't mean that it's not a really hard diagnosis to deal with, because your choice has been taken away, and it's still something that you didn't expect to happen. Because most of the time with POI, like you say, it is just for no reason. It just happens spontaneously, and that's a big shock to anybody. So yeah, there's a lot about having your choices taken away that's quite hard to deal with. And we say it is a grieving process. You do have to go through it like it is a big life loss, because it is. Yeah,
absolutely. Yeah, I couldn't agree more, Amy. And having had this discussion with somebody this week about it, and she went, I didn't know whether I wanted children, but I feel like that choice has been taken away from me now.
yeah.
Almost, what am I going to do? And that's really hard. Yeah, I think you're right. And psychological support is probably one of the most important things, isn't it?
Yeah, it is. And also I feel like one of the other challenges, I guess, that people find is that with the diagnosis, it's a complete postcode lottery in terms of what treatment you receive. So some people receive excellent treatment through their GPs. They get referred to an endocrinologist or a gynecologist, an expert one. But there's some places in the country where they get dealt with with their GP who doesn't have much training, and they're kind of sent on their way without any extra additional support, or without the right, they don't get sent for DEXA scans, they don't get follow-up blood tests. And I think this is part of the huge problem with this diagnosis, is the disparity in treatment. And I think that's why a lot of people do end up going to more private services, because they know it's guaranteed to get the blood tests they need, the scans that they need, because unfortunately there just isn't this equal treatment across the board. And I think that's something that people are finding so difficult and so frustrating. Some people do get sent and put on the NHS list for counselling. Other places wouldn't even dream of doing that. So that's a massive disparity that we find across the country.
Webinar on the way home.
So yeah, it's that's something that's a really big challenge, I think, for people. Like where I am, amazing treatment. There's other people that have been trying to fight to see their GP, even to have the initial discussion for years. So it's really a big frustration within the community.
Where do you live, Amy?
I live in the northeast, so I just live outside of Newcastle.
Right, yeah, because places like Merseyside are really good as well, I think, aren't they?
Yeah.
Where they've got really good health hubs, and they've been proactive in it. I know that Liverpool and that area, and then obviously
really good.
Where the centres of excellence around as well, isn't there?
Yeah.
And there's a few questions come through. So what I said, there was just one thing that I personally know that I got tested for, but I can't remember what the name is. And I know a lot of people that I meet that do say have a brother, a genetic brother, or a genetic son. My little ones are conceived through egg donor conception, so I didn't need it for me. But my mum and my nan both had POI, but this testing obviously wasn't around in their days. But I had it done for my brother because there's something genetic. Hazel, do you know what it is? Because I'm not medically trained, everyone, just to let you know.
Yeah, it's a Turner syndrome, I think, genetic test that they do, I think, but I'm not sure. I'd have to come back to you.
When we send across the email, I'll send across the details, because I know a lot of people, if they do have a genetic son or they have a genetic brother, it's very common for the either the son or the brother to be at high risk of dementia due to this particular gene.
Oh, it's going to be PO. It's going to be that PO4. It's going to be that one of those.
I'll just double check, because my gynecologist prefers
Fragile X. That's it, Amy Austin. Thank you. Yeah, it is Fragile X. Sorry,
Fragile X. That's it.
That's it. Yeah.
Something so easy. But yes, I think it's quite good for someone, if they, like I said, if they do have a genetic brother or a genetic son, it is good to be tested for them, because once you're tested, basically, if you come back positive, I come back negative, so my brother didn't have to take it any further, but if you come back positive, then your genetic brother or your genetic son can then go on to have the test, if obviously they wish to. So that was just a little something that non-medical me wanted to add. So just some questions. I had to pop off a minute ago, and you may have answered this one, so I did hear you say something about gynecologist. But it says, is it normal to be referred to a gynecologist as part of a POI diagnosis?
It should be, and it should be, but it should be a gynecologist who knows about POI, and that's really important. So actually, an endocrinologist should be involved with that as well. So it should be both. In an ideal world, you would see an endocrinologist and a gynecologist together. Often it tends to be just a gynecologist, but so that's how it should be seen.
Yeah, I think just from personal experience, maybe for you as well, Amy, that normally I've never been referred to an endocrinologist, but I am under a gynecologist.
I've only ever been with an endocrinologist.
Really? Well, there you go, completely different.
But I think that's because I was diagnosed as a teenager, so I was put in sort of the pediatric endocrinology, and it just carried on from there. So yeah, it's funny, isn't it? That's what we say. It's just everybody has a totally different experience. Yeah.
Yeah, so I suppose it's just not one size fits all, is it, I suppose? And, and I suppose obviously if they have experience now and expertise in that area, then it doesn't really matter which one, I suppose, does it? Someone said, what is the level you should aim for estrogen to be at around 29-30? So a healthy level.
There's no level that we can say you want it to be at. The actual guidance around estrogen levels for bone health, we want it above 250 pmols per litre, but actually when you're young, so if you're 29-30, I'd want to be seeing your estrogen levels up at around 600 ideally, because you want it to be that you're functioning with everything properly. And if they start dropping below 500, 480, 500, you can start struggling and you'll get symptoms back, and we're not protecting you properly.
Thank you, Hazel. HRT versus COP, what do the new guidelines recommend?
It's a personal choice, actually, and we've got some really good POP, not POP.
What is, sorry, for anyone who doesn't know, like me, what is
combined
OCP?
Oral contraceptive pill.
Oh, okay.
Okay. We've got some good ones now that do have estradiol. Amy, do you want to come in on that one as well?
Yeah, so again, it is a complete personal choice, but what I will say is there is currently the POI's research study going on, which is a long-term study looking at this exact thing, and it's going to be great. I guess it's to look at a long-term of somebody on HRT, on the oral contraceptive pill, to see how each one has protected bone health and heart health. To be honest, they're expecting it to be pretty much going to be okay, the same, but that's
which oral contraceptive are they using? Are they using Kalara or Zoli, one of those two?
I'm not 100% sure, but I think it's the way that they're doing it is it's a randomized trial, so I think they're each member's getting given essentially something different.
Right.
So it's going to be it's a long-term study, so I mean we mightn't get the results anytime soon, but it is something that hopefully we'll have more tailored information on at the minute. But I think for a lot of people, they find the oral contraceptive pill is a lot more convenient. Yeah,
absolutely. And when you're younger, the oral contraceptive pill it makes you feel less different.
I was on it for 10 years for that reason, from 16 to 20. I was on it from 16 to 25 for that reason, because they said, all of your friends will be on it anyway at the same age group, and it is just sort of more of an inclusive way of getting your hormones.
Yeah, absolutely. You're so right. Let's have a look. I know there's some more questions. Let's have a look. Right, I'll go from the top.
There's one there that's, do you need to carry on with HRT after 50? And how do you know if you need to?
I'd say you want to. I would say you probably want to. Probably by the time you get to 50, you'll be back on probably 50, 51, 52. You'll be back down to about a 50 microgram dose. So 2 pumps of estrogel, 1 milligram of Sandrina, or 50 microgram patch. But actually, you don't know. And this is it. It's not an exact science, and it is really individualized. And what I would say is that you don't know. The only thing I would say, don't stop it at 50, but I'd say maybe give it to 53, 54. You can then stop it and see how you feel. That's the only way you're going to know, in all honesty. And that's the big thing. So the COVID jab as well, we don't really know. Have you heard any? I've heard anecdotal stuff.
Yeah.
But that's all. I've seen women who've, Sorry, Amy, go on. What were you going to say?
Exactly the same. Yeah, we hear of it anecdotally, but no kind of actual research into why.
No. But it did make a real mess of some women's cycles, and it did do things to people. HRT normal dosage. What would I recommend? It's individual. I have to say, it depends on if you're absorbing it. I know somebody asked that further down, how do you know if you're absorbing it? We in our clinic, we do estradiol levels. The NHS won't always, but sometimes they do, especially in younger women. When we write to them, we'll ask them to do estradiol as well as testosterone levels to check that you are absorbing it, and we know that you're on the right dosage. So it is very much individualized once more. Would you agree, Amy?
Yeah, absolutely. From my personal experience, I'm on a massive dose of estrogen because I don't absorb it. I've been on about a tablet and 2 patches, and my blood tests have still come back that there's 0 estrogen in my blood. So I need a massive dose to even get a small amount in my bloodstream. So I think it is, again, that's such an individual thing. It's not a one size fits all. It's not this patch will give you this much estrogen. It doesn't work like that.
No, absolutely it doesn't.
And I think as well, following on from that, Amy, I've had a similar experience not absorbing. But obviously you've got to think not everyone can try to.
Tia, we've lost you. You've gone silent, Tia. So Tia, I'll talk for Tia while she's not here. Tia really struggled with absorbing a patch, gel, anything. She tried everything, and actually Tia's ended up with having implants, which is again very difficult to find. Tia has to pay for hers privately because she can't get funding at the moment, but she's trying to sort that out. And in Davina, is it body identical? It's not something we use very often, and if it's not, can your GP change it if you request it? Yes, they can. It's not something that we use very often nowadays. Let's have a look. Gosh, apps. Do you have any apps you recommend, Amy?
I mean, it depends what kind of support that it'd be looking for. You know, if it's sort of psychological support, there's a lot of apps out there to help, but I guess apps to support you with your HRT. I guess I don't know any of them. I suppose it depends what kind of support it is that you're looking for. Is it kind of, there's plenty of apps that kind of give you reminders to take your HRT and that kind of thing to help you on a practical level. I'm not sure if there's any apps I would say that would be reliable enough to give you accurate information on HRT to take and things.
I think you're absolutely right, Amy. I'd love to have an app that we did that was, and I'm just going to meet up with some app developers next week to see what they can do, because Amy's absolutely right. There's loads of apps for your cycle tracking, your symptom tracking, but what they don't give you is support when you have issues. What shall I do because I'm struggling with this? There's not that around, I'm afraid. Kate, your POI was diagnosed at 17 with clear FSH, but have always had high normal AMH levels are not necessarily that accurate. It's not considered. You need to, I would say, as you were diagnosed at 17, if you're thinking of having wanting to get pregnant, then I would say you need to be referred to your local fertility team and see. It depends on where you live, about fertility testing and treatment, because you need scans, you need a proper counselling around fertility and a discussion around treatment options. Has there been research done specifically on getting a diagnosis at the age of 12, 13 instead of puberty? Experience POI. Is there a difference in terms of bone health, cardiovascular health when you were diagnosed this young? I feel like it's different because it's all your body has ever known, and yeah, absolutely, you're so right, Neve, you're so right, because it is going to be it is going to be different. You know, what they do say is, when you're younger, I don't know how old you are now, Neve, but when you're younger, you have lower doses and then you work up, but you want to have a relatively good level by the time you get to 18, 20, I always think, because actually that needs to be better for your bone protection and your cardiovascular health as well.
Yeah, that's exactly what my experience was, Neve. I was diagnosed at 16 before I hadn't really finished going through puberty, so I had that exact experience. And I think it is one thing that I noticed was I didn't have those sort of typical menopausal symptoms, I think, because there wasn't that drop in hormones. It was more of actually having to build them up because there wasn't that menopausal drop. So it is a different experience, absolutely. Yeah, and I think sort of kind of following on from what Hazel said, I ended up with osteopenia because my levels hadn't increased the right amount until I was sort of early 20s, and then I was put on HRT instead of the contraceptive pill to kind of manage that a bit more. So yeah, I totally understand where you're coming from. It does feel like a different thing because you've never had the hormones to lose them in the first place. Yeah, and it is just important to get your estrogen to the right levels to make you function as everybody else does of your age. Yeah,
absolutely, and to protect your future health as well. That's really important. Younger women may need more estrogen. I've been on HRT for about a year now, using 100 microgram patch, 200 bioidentical progesterone. My symptoms have improved greatly, but you probably you probably, I would say for you, Jay, you probably need you need some hormone testing to see what's going on, because if you've still got fatigue, and managing your stress and your exercising, you would either need testosterone added in, or you need more estrogen in there. And although the guidelines say, the BMS guidelines say that, 100 micrograms is the top, that's because they never tested on anything higher. And it might be in your early 30s that you might need some more, but you do need your hormones. You need your hormones checking to see what's going on. And that's the big thing. That's what I'd say to you, Jay. It's really important to have that done. Would you agree with me, Amy?
Yeah, absolutely. Yeah, spot on.
Right. Initial DEXA scan is already showing lower bone density. That's not unusual. Therese, I would say, see how much you're on of your HRT, see if your GP will check those estrogen levels to check they're above 250. Welcome back to you. But yeah, and just check what's going on, because for osteopenia, and you're only young at 37, you do need those levels above 250. That's really, really important. And you've only been on it for 5 months, but you need that all checked regularly.
Sorry, I don't have a clue where you are on your questions.
It's all right. Well, I'm going through them.
Oh, good.
But 1942, my gynecologist doesn't think the oral contraceptive pill. Well, Amy's study's going to let us know. And in some ways she might be right. We don't know yet.
Yeah. I was told the same thing. I think I was taken off the contraceptive pill at 20-something, early 20s, because my new consultant thought the same. And I think it was more to do with that. I think with HRT, it's more tweakable, I guess, than the contraceptive pill. I think that tends to be what it's more about, rather than protection purposes. It was more like, actually, with the HRT, you can take more blood tests and add more in and that sort of thing. So there's a lot more flexibility with it, I think.
The other thing is, with the oral contraceptive pill, is we can't accurately measure what's going on with your estrogen. Yeah. And what does happen with the oral contraceptive pill is the fact that because it goes through your liver, and it's really complicated to try and with estrogen going through the liver, and the half-life and all those chemical reactions and all of that, and what happens with it. So we sometimes can lose up to 95% of that estrogen before it even gets out there. So that's probably why your gynecologist is saying that. Whereas with transdermal, it doesn't go through your liver. You're absorbing it through your skin, so you've got more of it bioavailable, so you've got more availability of it. So that might be why they're saying that in terms of bone health and cardiovascular health, that's why they think it's better. Yeah, brilliant. Thanks for adding that, Tess, about your progesterone as a pessary. Yeah, it's so Mutagestin or Gepratix, which is the bioidentical progesterone. You can use it as a vaginal pessary. There are vaginal pessaries that are available, but they're not licensed in the UK, but it can really help with anxiety and fatigue at times. Shannon. So Shannon, endocrinologist for 5 years and gynecologist, but I've since been discharged from both to GP care because the gynae doctor said menopause care is gaining traction. Should I still be advocating to see one or both of them now I'm in my mid-30s? I personally would say that I'd say you probably do need an occasional checkup with a gynecologist or an endocrinologist, because you're still only in your mid-30s, you're still only young, and that's, I don't want to be too controversial about it, but actually you do need to see a specialist about it. That's my feeling. What do you think, Amy?
Absolutely. I think anybody with POI should be under the care of a specialist in whatever way. Yeah. Unfortunately, with the NHS, that is quite often not possible, but I do think specialist care is needed. Yeah, absolutely.
Absolutely. And, when I started my clinic in 2019, I thought we would be on the road to the NHS. It got worse, and it might get better, but I don't know when. And Tess, I use it this. Oh, Jay, I think your estrogen's probably a little bit low, or something's going on there. You need your bloods checked. Lucy, thank you for telling us. I was becoming desperate. First, I stopped caring about life. Oh my God. I'm glad you got your life back, Lucy, but horrendous. It's horrendous that, and you're right, they don't know what to do sometimes. It's really hard. Lifestyle changes require specifically diet for hormones post-menopause.
Sorry, I've just interrupted. Just to go back to obviously Lucy, I think that's probably one of the problems that a lot of people think it's all about fertility, when obviously I got diagnosed whilst trying to conceive children. So for me at the time, yeah, that felt like it was it because that's all I was focused on. But it's a lot more to it than just the fertility element. Like that is an element,
Usually.
and to some it's going to be a huge element. To some, if they don't want children, it's not an element, but it's still a health diagnosis. It's not all about fertility. That's just one of the things it's going to cause, or potentially is infertility. But obviously there's many other elements to it, with obviously daily symptoms, struggles, etc. So I just wanted to highlight, obviously, for what you're saying, it's not just about fertility. And I think that's probably the problem with a lot of people, that they think as women we should be these baby making machines. And I think that's why a lot of people, when you do get then diagnosed with POI and you're infertile, you feel more alone and less of a woman, because you're made out to feel that that's what it's all about, is just making babies, whereas obviously us women are more than that. But not just that, POI is a lot more to it than just obviously wanting children. Like probably the same for you, Amy. Like obviously I've had mine now through doing etc. My symptoms are still there. I've still got my POI. Like it's and
I think one of the things that we all sort of I've always said is that this diagnosis, there's kind of three prongs to it. Fertility is only one of them. One of them is the health, which is sort of getting your medication right, dealing with your symptoms, sort of worrying about your long-term health. So there's all of the health things. Now you've got a condition that you've got to manage long-term. You've got to take medication. There's the health column. There's a fertility column, which is important to some people, isn't important to others. And then there's also the relationship side of things, which like I think Hazel mentioned before, which is, you've got your friends are having babies, how you feel about that. You've got to tell a new partner if you haven't met them. There's so much more to it. There's a lot of shame with anything to do with women's health and gynecology issues and things. There's so much more to it than just fertility. So I think we need to, sometimes like that, when you get diagnosed, there's a beeline to the fertility. Okay, let's fix the POI, because they think the infertility is the thing that needs fixing.
And it's not.
Actually, it's not. There's so much more to it. And like that, I have a daughter now that I adopted because that's the choice I decided to make. I was realizing actually pregnancy things isn't something that's important to me. But the fertility is one part of it that might be important to some people. It might be somebody's everything, but to other people, actually living my life to its full and feeling well and being healthy and not having long-term issues, that's the priority, which I know that was for me. It's like, actually, well, how do I get my health where it needs to be?
Yeah, and I totally agree with that. So lifestyle changes require DSV. Mediterranean diet's a big one, I would say, and there are thinking about things, although you just need to be really caring for yourself. Diet's really important. Things like isoflavones in your diet, so flax seeds and sunflower seeds, all those things. Omega-3 fish oils as well are really important because they can help with your joints and your brain health as well. And we talked about vitamin D and calcium, but there's a whole load of other things. But diet's really important as well to help your health long term. And we haven't really touched on that tonight, but that is a really important one as well. Or NHS psychological, specific NHS psychological.
No.
No.
There is, I know. I'm glad you two said that.
Yeah.
Yeah.
No.
No. And you know what? I would say, Kate, not only, I mean, I'm talking about menopause as well here. I went and gave a talk to our Southwest psychiatrists back in November. They didn't have a clue about any of this at all. And they wondered why they were suddenly had a huge upturn in women turning up with psychosis, and they didn't have a clue.
Yeah.
So I'm really sorry, but it's no.
Yeah. And that's why people end up paying for private counselling for that exact reason. And that's why Daisy Network have got this initiative now with National Lottery where we can offer a handful of 6 free sessions. It's not a lot, but it's better than nothing, because actually, unfortunately, you're not going to be able to find it other places. And there is British Infertility Counselling Association, but again, that's for infertility, and actually you might want counselling for other parts of POI. So yeah, unfortunately, you can go to NHS General Psychological Services, but they're not going to have the training to support you with your POI specifically, unfortunately.
Yeah,
I think you'd be probably your best bet would be obviously somewhere like Daisy Network, where they've got their specialist counsellors who obviously specialise in counselling, as well as probably many other things that counts with POI, where they can really focus on you in that element, and they have some kind of understanding, no matter what their story is, to get them to the understanding. But yeah, I'd probably, I think it's hard. I remember going to a counsellor, and bless her, she was lovely, and she actually did loads of research around POI, donor conception, because that's obviously something I was going through at the time, and because she didn't know anything about it. And since then, she's actually gone on like counselling training for those elements, because there was no one like out there. So, but still, she didn't, obviously, when it wasn't much use to me at the time, because she didn't have no experience in those areas, but she did go and try and research. I think there's people out there that would love to, but they just don't know about obviously these topics, to know that there is specific training maybe for that, or that how they could help those women.
So the ideal estrogen serum level for younger women, Jay, is around 600 in an ideal world. That's what we'd want it to be. It can be up to 1,000, but we wouldn't want it up at 1,000. 600 to 800 is okay. 600 is the ideal, really. And Kate, you're on a 200 microgram patch and 273. They put you on 2 milligram pill, and now at 30 your estradiol levels are 166. Oh God. Yeah, I'm afraid it is typical for GPs not to be able to, or to be willing to, because they don't know they don't know the levels. They don't understand enough about POI.
I think as well, they're not allowed to prescribe off license, are they, without a specialist?
They're not, because they
authorizing
haven't. Yeah.
I think the only obviously way around that, obviously I know obviously there's not no NHS support, it looks like, for you in your gynecology department. It probably would be seeing someone private maybe to get. I just don't think GPs best them understand results. I remember ages ago when my levels were through the floor, and they knew a gynecologist was looking at them anyway, so they weren't really taking much notice, but it kept coming back saying like they were fine, they were normal. And I remember getting on my high horse a bit and speaking to the practice manager and just saying, like, this is dangerous. I said, I'm lucky in some way that I can read my results, so I know it's not okay. But there could be a younger girl that's diagnosed, doesn't know how to read her results. It comes back and says fine, and then she's just struggling, doesn't go and get the help because she thinks, well, it's fine, this is just it. So I think I'm sure obviously Michael was not going to change anything, but I think it's just a shame they just don't really understand. So yeah, Dr. I think the only thing would be, unfortunately, I know it's not the answer to have to go private, but
or you can ask your GP to change your 2 milligram estradiol pill to something like Sandrina, and you can go up to 3 milligrams of Sandrina, 4 milligrams. It's on the BMS guidance, so you can have 4 milligrams. Sandrina is a little sachet, works slightly differently. It's still estradiol, but you can go up to 4 milligrams, and that is still counted as being within their prescribing range. So I would go back to your GP first and say, can I change it to something else, and suggest Sandrina, because you can start off on 2 milligrams. And the reason your 2 milligram estradiol pill is not working, and because, as I said before, it gets bound up in the liver, so you don't get all of it. So it's probably worth starting on something like Sandrina at, probably you go straight in at 2 milligrams, and then you could work up pretty quickly to 4 milligrams.
And also, just to mention on that is, I don't know if many of you, not on what you can go on, but if obviously you can't get the support from your GP, and obviously it's not financially feasible for you to go private, which for many of us, obviously, it's not, which I totally understand. So if that's not obviously an option for you, there's also, who we do a lot of work with, Diane Ziebrink at Menopause Support. So that's where, when I started off, I used to do an awful lot of work with POI, women whose GPs weren't supporting them, and so a lot of my quotes that I used were women I've seen through them, and they're really good, and they do some free stuff as well. Yeah, she does. Ever so often they offer free consultations, so do give them a follow, because they always pops up on their socials, where obviously you can request obviously a free support from them, which is amazing, as and when, obviously, if you need it. So yeah, there's that option if needed.
Yeah, brilliant. And I can see Sarah's joined a Facebook group called Premature Ovarian Failure Primary Ovarian UK, which is helpful for any questions that my GP doesn't know how to answer. Brilliant. That all the questions?
Yes, I think that's all.
Brilliant. Thank you very much, Amy, for joining us this evening. It's been
Thank you for having me.
Thank you very much.
Lovely.
And thank you everybody for being part of this. It's really good. And what I would say is, it's going to be recorded, it's going to be on YouTube, and it'll be sent out to anyone who's been here. And yeah, somebody's put a thumbs up to the P600.
Yeah, so thank you everyone. I will get the link sent out to everyone, so everyone can watch it back. And any other resources we think may be useful, we'll get those out to you as well.
Yeah, and if you want some more advice around diet and stuff, we have got it. I just haven't got it on me tonight, so we can do something specifically for you if you want any help and guidance around your diet and exercises. We have got stuff we've done, haven't we, Tia?
We have.
We've got loads of resources like that. So yeah.
I think you can go on and talk forever, can't you? So
oh yeah, I can.
Yeah, no, but no, I didn't mean you personally.